I'm back. So kia ora, everyone. Thank you for coming, and I'm truly sorry for not being able to show you some slides. I think talking is probably going to be okay. There'd be a little bit of addition. There's a couple of things I want to show you that I'll bring in. But really, I wanted to talk about sustainability in emergency medicine. So I started my sabbatical with this focus on sustainability in healthcare. I kind of got interested in that, and I took it to mean planetary sustainability. And initially did some courses on carbon accounting, on procurement, looking at that sort of stuff. But I really felt like there were several elephants in the room. And the first is that sustainability is far bigger than carbon, and it involves everything that promotes human and planetary flourishing. So looking at carbon really narrows the view way too much. And it also involves the sustainability of our health service and the people in them, which is something that people don't tend to talk about. And secondly, the biggest driver towards the lack of sustainability, it became really obvious to me, is actually healthcare is delivering too much healthcare, which we're clearly doing. If health was a nation, we'd be the 5th biggest emitter of carbon on the planet. And then interestingly, the biggest correlation with carbon footprint for both individuals and nations is purely how much money we have and how much we spend. So this myth of the kind of green consumer with your Tesla and your solar panels on the roof are not going to save the planet. And the science is really clear on that. And neither is the promised biogas-driven hospital boiler. Although clearly I'm definitely not arguing for keeping the coal or keeping the fossil fuel cars. They are not the solution. So we're this integral part of an infinite growth economic system, and we're pushing up against the boundaries of this finite planetary resource now. And healthcare is this insatiable consumer of these resources. So there's a really large body of literature looking at wasteful healthcare. And by some estimates, up to 40% of the healthcare we deliver is either of low value or actually harmful. And so delivering more and more healthcare is not necessarily better. And then our systems are based very much around disease care rather than healthcare. People are living longer and longer, but with chronic disease. And much of it's driven by lifestyle, which is complex and multifactorial. So our economic systems, our food systems, the ways of living, they all promote increased reliance on more and more and more healthcare. And then GPs have 15-minute appointments, and it's far easier to prescribe medication than it is to engage in some sort of meaningful process of actually trying to change the way someone's living. And even if it was incentivized to do that, then the social determinants of health, the ubiquity of processed food, the increasing stress and social media and our political landscape, and all of it would make it incredibly difficult. So the health systems become incredibly pressured, and sustainability of our basic functions are threatened. And then the sustainability of our staff is seldom considered. So our people, I've absolutely come to believe, are our greatest resource. And I think often we're treating them poorly. And then climate change is going to have massive effects on health. And those effects are going to disproportionately go to the most deprived. So in summary, looking at all that, the demand for healthcare is just going to continue to increase. And our ability to deliver it is going to become increasingly threatened unless we really start to rethink the basic paradigms and start to think from first principles. So then why systems thinking? And systems thinking is this powerful tool for understanding complex things like health and climate. So health's this archetypal complex system where there are multiple diverse agents or people with ostensibly the same goals. Although honestly, I think we actually have really quite different goals throughout health, with these unpredictable outcomes and these unforeseen consequences which abound. And you can't reduce the system to its parts. Relationships between agents are absolutely key. And so single component solutions pretty much inevitably fail. I'd like to try and, I'm just going to try and share my screen if I can to show these diagrams because I think they're really illustrative. Give me a second, sorry, I need presenter view. Sorry, it's not coming up with my letting me. Speaker view should let me share my screen, but I haven't got a screen share thing for some reason. Any ideas, Alex, where that would come up? It came up briefly. I'll give up on it in a second, but for some reason I'm not getting a screen share icon coming up. Yeah, sorry. Cool, I'll leave that. I'm truly sorry, but basically what I wanted to show was the difference between the classic kind of linear top-down systems organizational structure that we see all the time and then what a causal loop diagram, which is a great way of looking at a complex system, looks like. And basically in one, you've got this nice, neat set of kind of top-down, hierarchical, well-organized system. And then when you truly represent what's happening, it's messy and complex and it's relational. And there are these kind of important relationships that you might not actually see from the surface, which drive a lot of the system behavior. There are feedback loops. There's these unintended consequences of doing things. There are tipping points, and nothing behaves as the person at the top of the kind of nice, clean organizational chart would want it or expect it to. So change can be top-down or bottom-up driven, but if you have empowered bottom-up change, it's a far more powerful force than top-down force, and the change must have stakeholder buy-in. And so then this idea of feedback loops are incredibly important. So you've got these balancing loops which resist efforts to change, and then these reinforcing loops which drive change. Balancing loops are everywhere. If you think about how homeostasis works, all of those systems are kind of balancing feedback loops. And a really good example is entrenched practices are balancing loops. So we as healthcare providers tend to resist change even in the face of strong evidence. There's heaps being written about this, and we see that all the time. So there's the idea as well in systems thinking of complicated versus complex systems. So a car is complicated. It's got lots of different moving parts. It's complicated to put together. But if you remove one key part, the whole thing doesn't work. A forest, for example, or a healthcare system is complex. So it's relational, it's actually pretty resilient and robust. And if you remove one key part, the other parts will compensate and it will continue. So reality is really messy, and it's the relationships that are crucial. So often unexpected things happen and change can be nonlinear. Another cool thing about systems thinking is thinking about the concept of illumination and changing the kind of eco-structure or our culture and our way of being. So you have to frame a problem in a way that makes sense to and incentivizes each stakeholder. So I don't know how many of you followed Saxon Connor from Christchurch, surgeon from Christchurch, and his forays into the media. He's done some fantastic work on this stuff, I think really brave work, which I'll talk about a couple of times. But he wrote a great article in the New Zealand Medical Journal kind of framing the same problem for surgeons versus emergency doctors. So as emergency specialists, when we see the place building up and bed blocks starting to happen in the ED, often our solution will be to say, can we cancel elective surgery because the hospital hasn't got enough beds? He points out, and I think it's fantastic for us to see this, that's obviously not the right solution, because that then disadvantages the patients with cancer waiting for their elective operations who now don't get them. And that we're all protecting our own little piece of turf, and actually the solutions need to be systemic and take all of this stuff into account. The concept of eco-structure is kind of the idea of just the culture. So for example, in Germany, when you drive off an off-ramp, it's a nice, structured, organized way of each car lets one car in, then they go, then they let one car in. And the culture is that happens pretty much every time. Whereas next door in Holland, it's totally chaotic and every man and woman for themselves, and they just cut each other off and try and get in as quickly as they can. And what's interesting is that when Dutch people go and drive in Germany, they quickly adopt the German way of driving and vice versa. So it's just an illustration of how we can think about changing our eco-structure and culture.
Tom, do you want to try to email that to Bruce, and Bruce can forward the slides on if you want to try it that way?
Great, because it really works a whole lot better with the slides. I'm truly sorry about this. I could present it.
Can you see if you can do that?
Yeah, sure. I'll do that now. I've tried emailing myself a copy and it hasn't seemed to go through for some reason. Cool, let's email as attachments. Yeah, sorry, I'm aware that it's suboptimal. How's that, Bruce? I've sent it through. Should be.
I'll open it when it arrives. Hasn't transferred yet, but
cool.
I'll open it and then I'll share screen, assuming I can do something with it. If and when.
I'm just going to try again and see if there's any reason that I can't share screen. There we go. I've got share screen there available now, interestingly. So I'll bring that up. So you should have my screen there now. I'll play that. That's the diagram I wanted to show you guys about the difference between a simple view and a complex view. So this is an organizational chart of how we'd like our organizations to function. And this is from a great group in Macquarie in New South Wales, who've done a lot of work in complexity in medicine, who've drawn a causal loop diagram of what a functioning emergency department looks like. And you can see it's kind of messy and complex and entirely different from what we're talking about. So I'll just show this again. This slide's kind of nicely illustrates some of the complex thinking and of systems thinking. Is that basically we think about interconnections, we think about things being circular rather than linear. This idea of emergence, that the parts are greater than the whole, and on the other side is a flock of birds. So each of these birds is actually following like a really basic and quite simple set of rules. But what emerges is something very complex and quite beautiful and quite unexpected. And we see that all the time. And actually, that's what an emergency department is. If you just put it together, it's a bunch of doctors and nurses in a building. But that's not what we are at all. It's actually a far more complex emergent system when we can deal from anything from a kind of a multi-patient trauma to a runny nose. Although, again, to be clear, we really don't want to deal with the runny nose. So please don't send us the runny nose. This is, I'll bring... see if I can share this again. I think that's going to be difficult, so let's just move on. So stakeholders and relational systems. So I think one of the reasons that Te Whatu Ora and other top-down organisational restructures often struggle is that we don't have full stakeholder involvement from the start. And that when there's engagement, it's not framed with the right illumination to really get people owning it from their point of view. Again, that concept of illumination is key. You have to frame something in a way that makes sense to people so that they want to be part of it. So that applies to the way we try to drive change, by the way, too. So we need a shared understanding from all the people that the change is going to affect, with our managers, our nurses, our junior staff, rather than just deciding we're going to do something and trying to do it. Otherwise, we end up getting frustrated when people don't see things our way, rather than understanding that actually all of these stakeholders need to feel like they own this problem and own things. And so systems are just entirely relational and contextual. And so thinking about people and systems is not the right way to think about it. It's really very much about people in systems. So people and systems and the way they interact and the emergent properties are really what is useful, I think, to start thinking about. So there's some other really cool tools, I think, just for thinking about thinking in systems. And the first is don't start with the answer. We often do that. We start with where we think, what we think the answer is, and then we go backwards and look for the question. And so also thinking about what are your cherished assumptions. We've all got assumptions that hold us in certain views. And so the question is, what would it take to change those assumptions? I guarantee you've got them. And it's an honest look at yourself and start to think about what would have to be true for me to change this way of thinking. And then the idea of, if you tell me how you measure me, I'll tell you how I behave. One of the problems, I think, is I'm not sure we truly measure what's important. We often measure what's easy to measure rather than what's truly important for our patients and our systems. So then why am I doing this talk? This leads on really to what I'm was hoping to achieve with this talk and a series of these talks I've given and planning to give throughout some EDs around the country. So this talk was meant for emergency medicine staff, but I think it translates really well to anyone who's involved in either the governance or provision of acute healthcare, and particularly the next generation of health professionals, the junior doctors and nurses, and other health professionals. So I'm really hoping to kind of stimulate a conversation and amongst healthcare staff, but eventually, ideally, the public. And it's obviously, this is one small piece of this conversation being stimulated. There are lots of people doing work all around the country. But I think as one of the themes I want to keep coming back to is all of us have to do our bit to kind of stimulate the conversation, to drive things from the ground up, from the bottom. So to start to look at our issues from first principles and have everyone start to think about, like, why are we doing this thing from first principles? And to use it to imagine how an alternative might look rather than being wedded to some of our current ways of doing things. Then to really understand what are the points of difference? What can we do that might really make a meaningful difference? I'll bring that bigger, sorry. And then to have a conversation with you guys about how that looks. What things might we do to go from A to B? It feels big and daunting, but what little things along the way might be helpful. So I'd really like this to be somewhat interactional. It's been the idea of these right from the start, is me talking to you isn't the idea of this. And I think there's some utility in sharing some of the ideas and the structure, but then I'm really, really interested to hear what everyone thinks about some of these concepts and some of the ideas around basically our EDs and our place in the system and the pressures we're going to face, about ED as a paradigm and emergency medicine, and what are we actually trying to do? Talking about over-testing and wasteful care, and why do we do that? What are the incentives that drive us to doing that? The importance, I think, absolutely crucial to all this is the importance of the next generation of people, as I've said, and how we look after them and the values we pass on to them. Because I feel like at the moment, some of the values we're passing on to our junior staff around what we do are continuing to drive a culture of which we're going to struggle with in the future in terms of the way we test, the way we look after people, the way we treat patients, the way we think about over-testing and over-diagnosis. So please, at any point, if anyone wants to chip in, please do. Pamela.
Yeah, it's great, Tom. One of the things I think that you have to start on very small things. If everyone does very small things, you can help. So one of the things I find quite irritating is how the ambulances pick up these elderly, frail people and bring them to hospital when they should just stay home. And one thing that has been helpful is if the person has a care plan that the ambulance can see that says this person doesn't want to come to hospital. And that's something that we should all be working on with these people when they're in hospital, establishing, do they want to come to hospital and have all this stuff done? Because as soon as they come to hospital, they get a CT scan, a troponin measure, a CTPA, and it's all just a waste of money and time and harmful for the person.
Absolutely. And so the question is, because we feel frustrated and we're like, why did they bring another ambulance, this person in again? But yeah, that the empowering way is absolutely, it's a beautiful point, is to think about that patient up, but we can start to advocate on some of these small levels for some of these things which slowly drive change. And it feels hopeless, but eventually the thing that has been really revealing to me through going, looking into complexity science is you try something 10 or 15 times and you feel like you're beating your head against the wall, and then suddenly you get this emergent phenomenon and you get a state change and things start to change. So yeah, absolutely. It's a message of hope, I guess, is what I'm trying to put out, is keep doing exactly that, and hopefully we start to drive positive change. Steve?
Yeah, I think a lot of the things that are done out of fear of retribution. Like, I'm pretty sure that EDs in the past, that may still be the case, is that you can't actually turn anyone away because of legal implications. But, we'd have to have a complete change of mindset or even a legal framework to allow to get rid of that kind of that fear. And I've just always, taking that extra step, but might be carrying the patient to hospital or admitting into the hospital when in fact the most obvious or sensible course of action would have been the opposite, So yeah, I think that's a thing in the background, just that fear of getting involved in the legal system.
I totally agree. I'll talk about that a bit later, and I think we should talk about that more, because for me, that's actually sits at the heart of all of it. It's the expectations from society at large, and as importantly, I think we drive a lot of that. Like, we drive a lot of the culture that eats our young, effectively, and I think we shoot ourselves in the foot massively, and we hinder our ability to do the right things because we're scared. So totally. And again, I think changing that eco-structure, that idea of eco-structure or the culture around how we address when things go wrong, I think is super important. Yeah. Kathleen.
I am probably coming from a more of a consumer point of view, but it just appears to me, and this is only my observation, that the whole of society has this expectation that they can come to hospital and get fixed,
Yeah.
rather than looking at themselves and what they can do for their own health and improving their health long term. And that education side of it seems to be really lacking. That's just my 2 cents.
Yeah, I absolutely agree. And I think it's a really difficult problem because we've changed the way our expectations in society, we've changed the way we outsource responsibility onto others. And that's going to be a really big thing to bring back, even down to seeing sick children. It's difficult. Everyone is worried about their children, but worked on the floor this morning. I've seen 2 kids who honestly didn't even need to go to a GP, let alone an emergency department. Both of them probably consumed $600 or $700 worth of acute healthcare, in terms of an ED presentation for me to say, look, he's going to be fine. And that's a real change in culture as well. That's just a small thing. But
is that due to a lack of understanding of health by the parent? Understanding what goes on in the body and understanding how the body functions and just the process. I know I've had kids, you get worried about them, you rush them off, but what you can do for yourself is sometimes quite a bit better.
I think it's really complex. And again, like the complex system thing, I think it's driven from a change in culture where we've fragmented our systems to be consumers. Our elderly get shoveled off to rest homes rather than being in our homes and able to provide, care for the young. There's all sorts of things, which is a long way back. And I guess that's the big message. It all feels big and hopeless, but if we just start to think about the small things we can do to drive change and do it in a meaningful and thoughtful way, I think eventually we can hopefully be part of slowly turning the ship 15 degrees. We're unlikely to turn it around, but we might turn it 15 degrees. So then I wanted to talk about emergency medicine, basically, because again, that's my framework. That's where I come from. I'm aware that we're one small piece in this big puzzle, but I came at it from this because that's what I do. What I wanted to do is look at us contextually, and it's fantastic to talk to lots of people from different areas. And I think that's actually, absolutely key in all this stuff. So ED is this kind of pragmatic generalist medical specialty where we're at the kind of nexus of the acute health care system. We've become basically the single point of entry into acute health. And I don't think that was ever the intention. We've historically provided this excellent service to all with acute healthcare needs. And ED has had this strong ideology that access for all, as Steve says, we never turn anyone away. Everyone with a perceived health need can come to the ED and we'll look after them. And I think our ability to do this is clearly near failure point. A nice analogy, I think, is that of the hypovolemic young patient that most doctors can identify with. That's a classic complex system things. We're compensating. So we've bled 3 liters. We're tachycardic, but we look okay and we're still talking because everything's running massively under the hood to compensate. But what people don't see is the tipping point. At some point, we bleed that next 500 mils and we fall down dead. And that's the idea of like sudden systems collapse. It happens with banks, as we're seeing, in the last couple of weeks. It happens with kind of all complex phenomena. And it's starting to happen within our health systems, and not just emergency medicine, within acute services, within the hospital, within GP. All these other places are at these points where actually the stress is such that there is risk of system collapse. And it's being held together by good people doing their best at the moment. But then there's just this increasing burden of unmet need, and that's fallen disproportionately on kind of emergency medicine as the place that can't say no. And one of the things I want to talk about in this talk is, I think what we've lost is this compromises our ability to fulfill our core role. So I'll talk in a couple of slides about what actually I see our core role as being. And increasingly, it feels like sometimes we struggle to do that because we've got all this other stuff. We're really contingent on this whole system performance, and we often feel like we have little agency over that. But it's also important not to play the victim. I think we in emergency medicine have some limiting central beliefs, which we don't help ourselves with. I think we actually over-rely on evidence-based medicine, for example. I think we have this focus on throughput and turnover rather than truly meaningful health interventions. So I think we have to look at ourselves as well. We're part of this complex problem. So it's easy to feel frustrated and hopeless with this stuff, but by taking some agency and kind of connecting with others and really, putting emphasis on the relationship, and by kind of thinking about our eco-structure and what do we want to be true for that, then I think that's our best chance of actually making a meaningful difference from the bottom up. So I'm going to share this slide. I'll bring this up just quickly because I think it's worth looking at, because we're in the middle of this profound demographic shift. So these curves are the New Zealand demographic from 67, 2022, 2048, 2073. So you can see what's happening to our population in that time. And as that happens, health spending as a percentage of per capita as well as absolute just keeps going relentlessly up. So people over 65 are 14% of our New Zealand population currently, and that's going to be 26% by 2050. And then somewhere like Nelson, that's far higher actually. I forget exactly what our number is, but it'll be closer to half the Nelson population by 2050 when you look at the demographics. And the money that's consumed, the average 85-year-old uses 16 times more healthcare than the average 45-year-old. And then if an 85-year-old's in their last year of life, the way we're delivering healthcare now, it costs about $22,000 per annum for that last year of life for an 85-year-old. I think there's a big equity issue with this stuff. So Pakeha life expectancy is longer by more than 10 years. So all this increased health spending is disproportionately on the elderly. And then if we wanted to be more equitable, a kind of a reinvestment with more spending in preventative healthcare and the social determinants of health, rather than our secondary and tertiary services just hoovering up all this money, might be more equitable. Really thinking about true healthcare rather than disease care. Because if we keep doing what we're doing, it really seems like there's absolutely no way we're going to be able to afford healthcare for all in 20 years' time. So disease span and this chronic disease just keep increasing. The number of people, for example, with type 2 diabetes is expected to double in the next 20 years. And people with type 2 diabetes are getting younger and younger, and all the complications associated with it are being seen younger and younger. So it's been pretty widely written that diabetes itself could bankrupt the US healthcare system within the next 20 years. And that's just one, albeit major, but one chronic disease. So then we've got the other stuff happening in the world. We're going to see more. I'm just going to close that door. Sorry, 2 seconds. So we're seeing kind of more economic instability. We're going to see more. We are seeing more extreme weather events, and then increasing inequity. And all of that's going to further stress the health system. So the media environment is becoming more polarizing and adversarial. There's more and more stuff attacking the healthcare system. And then anxiety and other mental health issues just continue to increase. So we're basically facing this vastly different healthcare environment to when most of us started our careers, or even today. And the way we're designing our healthcare system and building our healthcare system is based in the old paradigm. We're building, a hospital which is based around a kind of 1950s or at best 1980s model of care. And the innovative kind of healthcare systems we're going to need to address this issue is going to need different buildings, different systems. And I think at the moment, throughout our system, we're not really responsive to that. So none of this is going away. And basically by starting to think about how we can control the things we can control, make relationships and start to change the culture slowly, I think it's the best way to actually feel like we've got some agency over this stuff. I think it's time to rethink the basic paradigm of emergency medicine as part of this. So what is the ED actually here for? And what will it look like right now if we designed a whole system from scratch? Where would ED sit and how would it look within that system? There's this fantastic Canadian Journal of Emergency Medicine paper on saving emergency medicine, which I'm happy to share with anyone who's interested. I think it's a really good read. And it just thinks about what the ED should be like from first principles. And I thought quite a lot about this when I was away and kind of talked to a lot of different people. And I came up with this list, and I'd be interested to see if anyone's got anything to add to this or how they'd order it. But I thought our primary role is the ability to intervene meaningfully in life or function threatening illness and injury in those who can substantially benefit. And that's not a lot of the patients we see. I think I'd argue that's not the case. Then we need the ability to rapidly and accurately identify those people, and the ability to rapidly and accurately identify other care venues for the patients who present with acute health needs who don't meet that, and then a way to actually get them to those places. I think we then, further down the list, need the ability to provide definitive care for kind of ED type injury and illness not requiring admission, like fractures or pneumonia or cellulitis that can go home. And just as importantly as the other things, I think we need the ability to create a vibrant, supportive, happy workplace, which fosters the ideas of kind of autonomy, belonging, and competence in all staff, and particularly is free from fear and frustration, which I think is what a lot of us work with now. I'd love to see the ability to make rational decisions around tests and treatment without a fear of personal consequences, Steve was saying, unless there's clearly malicious behavior. It's pretty rare in healthcare that there's truly malicious behavior. Consequences should be for systems. Consequences shouldn't be for individuals. And then we want the ability to provide compassionate care in a healing setting for patients within this scope, because it's really quite clear that we can't provide compassionate care in a healing setting for all the patients the system currently perceives should come to us. And we need a way to then get the patients who don't fit those criteria, as I say, to an appropriate care venue. And then sitting underneath all this, we need to be able to do all of this in a framework which promotes equity. So I don't know if anyone's got any thoughts about that and how that looks, and then how that looks compared to what we're trying to do right now. Because for me, it feels like we're a long way from that right now. Because our paradigm in emergency medicine basically came of age in the 90s, and it was kind of at the height of Taylorism and the industrialization of medicine. Yeah, Pamela.
If we just think about one of those things you talked about, which is that ability to have autonomy and to have I can't remember the words you used, but a caring environment where people are happy to work. If you can create that, you can actually get a much higher work output out of every single person in the place. So that actually enables more work to be done, just because everybody comes to work and enjoys it and is happy and feels supported and wants to help their colleagues. So if we just look at that one little aspect, which doesn't cost any money, which is kindness to everybody, that actually can have quite a good effect for on every single person in the organisation.
Absolutely, yeah. I think it's key. Kindness in our culture. I think it does cost a little bit of money. I think the organisation needs to invest in, for example, some of it is actually physical space. Like if people have break rooms which feel comfortable and they can get a true rate. There's things like that that do need a little bit of investment, but absolutely a lot of it is driven by the people. So one of the problems of ED is we've got this paradigm of productivity, goals and targets, safety as reliability rather than safety as person-centered. We've got this evidence-based medicine, which we're very proud of as emergency medicine physicians, and I think we've gone too far with it. I mean, one of the problems with biomedical studies is loads of them are total crap. We do a lot of, there's a lot of very low quality literature which we adhere to. They're often single variable, and they don't allow, one of the problems with biomedical science full stop, and it's starting to change with these platform studies. But before that, even the randomized trial was single variable. It doesn't allow the kind of complex and emergent nature of multiple variables, interacting systems and context to come into play. And I think we need to acknowledge that. The other problem we have in ED is this paradigm of worst first. And I think that can potentially be fear-based and drive over testing, because everyone's terrified of missing the aortic dissection or the, insert serious diagnosis here, the spinal epidural abscess, whatever it is. But we really have to start to accept that risk is probabilistic, which means that someone's going to miss that diagnosis. If you do this job for long enough, you're going to miss serious diagnoses. It might be you that's the next one. And so I think a compassionate approach to understanding what goes wrong in the system, but that the individual's doing their best with what makes sense to them at that time. So I'm going to be provocative again and say, I don't actually think we need a bigger ED or more doctors. If we actually did the work that is truly emergency medicine, and the rest of the system was well functioning, I suspect our workforce and space would be entirely inadequate. But at the moment, we're a long way from that. And so the surrogate is we ask for more and more resource. So there's this massive asymmetry of consequence. If I do the CT abdomen these days, there's no possible direct negative consequence for me. But if I don't do the CT abdomen and I miss something, this sure as hell is. So there's this great quote that I forget exactly where it came from, but the fear of having someone harmed by a missed opportunity is a strong and motive driver of overtreatment. And it comes from doctors truly wanting to do the best for their patients, but not understanding that by overtesting and overtreating, we're actually doing net harm in this big picture of a resource-constrained system. The system bad outcomes are hidden, and it's really hard to apportion blame. You know, the system bad outcome is the ED waiting time that blows out, so someone doesn't get seen and goes home. And that's not your fault as the individual, whereas if you don't CT the patient as an individual and something bad happens, you're held personally accountable. So these headlines are kind of a great example of that kind of adversarial fear-based culture which drives those things. And I think there's still a strong driver there. I've been doing HDC advisor work for 8 years now, and the culture is really apparent. The new commissioner is far better, but the previous commissioner was kind of not really interested in resource limitations a factor. There's this really human desire to blame someone, and I think it's incredibly corrosive to a quality of culture of high quality healthcare. Because the Swiss cheese model, which we all talk about, it's not correct. Outcomes are emergent, they're not resultant. These outcomes, they come from complex interactions of humans sitting within systems. So people do things that make sense to them, given their goals, their understanding of the situation, and their focus of attention at that time. And to go back and look at it retrospectively, it's almost impossible to get that context. So it's really not about the people, it's really not about the systems. It's about people in systems and how the people work and interact within those systems. And that's the bit that we don't hear much about. There's some fantastic mahi kind of starting on this with Hitoki no Matariki Aotearoa from HQSC, but it's still pretty small. It's got limited funding. You don't hear much about it. I'm hopeful it's the start again of one of these movements that drives things forwards. And there's some really good people there, some really interesting people, but at the moment it's not dominating what we do. So it's about how do we kind of change this culture? I think we have more agency than we realize. And as Pamela says, it's about kindness. I think we need to be kind to ourselves, to our colleagues, and particularly to our trainees. We need to accept that risk is probabilistic, that there are going to be bad things happen, and that addressing system factors and not individual factors is crucial. Because as I say, people make the decisions that make sense to them within their context at that time. It would be fantastic to see an HDC where individual practitioners weren't even named and identified unless they did something actually malicious. And then a process that took a kind of open look at systems and resources. So, and then there's the public conversations. I don't know how many of you had read Sachs and Connor's article and stuff about this, about rationing of healthcare. Yeah, it's worth a read if you haven't. Steve.
Oh, sorry, I was just going to comment on something said before, but I was just going to say that, you know, from my observation, I mean, clinicians are really good at focusing on the patient in front of them and doing the absolute best for that patient, but they're not very good at really focusing on what's best for the community. So, you know, like in our acute theatres, for example, you know, a huge effort will go into one patient and spend an hour setting up complex monitoring, get somebody through, but you don't see the sort of focus on, oh, okay, it would be good if we shot through a whole lot of these patients and actually get a volume of patients through, because you know that if you can get people through, actually you're probably saving lives on the waiting list, because people are dying on the waiting list. You know, classic cases is like pancreatitis from gallbladder disease, you know, which can flare up. But, you know, we're always cancelling these patients with who are having a lap colic, because on the surface it doesn't seem to be such a big thing. But, you know, we've got to think at the other end as well. What damage are we actually causing by the way we approach the care of patients?
Absolutely. And even that's only narrow within the acute healthcare system. So again, just to be really provocative, imagine if every time someone got a hip joint replacement, which is highly incentivized, on the consent form was this $25,000 could be used for primary preventative healthcare in Māori children. Are you sure you want to have this operation? You know, we're not going to do that. And I think that would be ethically problematic, but just to think about things like that, because it's all the same pool of money. It's not magical money. It's not, these hip replacements aren't coming from an endless pool of money. They're coming from a finite pool, which I'll talk about a bit in a future slide. But yeah, Pamela.
Yeah, and one of the elephants in the room is how much money we spend on cancer treatment, which is so prioritised because of the government push to it, because it's considered so bad if you don't prioritise cancer treatment over other medical conditions that are also treatable and manageable. And then we saw it that we spend $9 million in Nelson just alone on pembrolizumab, which enables people with cancer to live a few months, maybe a few years longer. And yet, as you say, we could be spending it on other things, and those are the hard conversations no one wants to have.
That's right. I remember reading an article published when they looked at the money spent on COVID versus the money spent on type 2 diabetes over the course of 2020 through 2022. And it's, when you look at the morbidity and mortality from type 2 diabetes compared to COVID, it was, but it was a politically unpalatable conversation to have. So I'm going to skip through to over testing. I think this is a great slide, which I'm just going to bring up. This is the rates of, I did an audit of Nelson ED CT ordering. These are CT abdomen, CT head, CTPAs, and then the total number of CTs. And this is 2015 through 2021. And so we've more than 3 times the number of CTs we're doing in all of those things and overall in the course of 5 years effectively. And in that time, we had about a 15%. So it was about a 350% increase in CTs for a 15% increase in presentations. So it's important to think about the unintended consequence of that. And again, going back to what Steve said, so there's harm to the person, which is overdiagnosis, which I can talk about. There's an opportunity cost to the system, there's an equity issue, and there's these tipping points, which is the bit people really don't think about. So our CT scanner gets so overused now that it starts to fail regularly because it's spinning far in excess of what it was ever designed to do. And that means it fails completely. So you have a 48-hour or a 72-hour period with no CT in the region, and that has like severe health consequences for a large number of people. So each individual CT we do just feels like, okay, we'll just do another CT. And actually the weight of all of them reaches this tipping point where suddenly the machine falls over and we've not got that valuable resource anymore. So again, I think that goes to what Steve says around individuals being great at looking after the patient in front of them, but not being careful stewards of precious resources. And then the question is, someone might say, look at that graph and say, well, are those scans actually appropriate? I think it's very, very difficult to tease that out. My intuition says absolutely not, and my experience working says not. But it's very difficult to get data on true, meaningful outcomes. You literally have to go through all of 7,000 scans individually and comb it out because we don't have good data collection systems. So, I think about all of the CT abdomens now. That I think these CT abdomens lead to overtreatment. Like we do a CT of a belly, it shows a thickened colon, which before was probably just gastroenteritis. Now we see these words written down on a paper, and someone's rung us with this report. And we feel too fearful to send that patient home because they've got something on a CT report. So they now get admitted to medicine or surgery with this thickened colon for what was probably always a benign diagnosis. The same with small subdurals in elderly patients, which I suspect we never would have done anything about, that we now know about, and we feel uncomfortable sending them home. So I think this ordering is driven by this change in culture and by fear. And so I want to remind people of these kind of great 4 principles of testing, which are firstly that the patient doesn't have a disease in ED. They only have a probability of disease. And the diagnostic test is merely a revision of that probability. That test interpretation should precede the test ordering, which I don't think we always do. So not ordering a test until you've already interpreted what the results are going to be. And then if the revision of probability caused by that test doesn't actually entail a change in management, then don't do the test. So here's a story from a few years ago that I always remember. Was a 23-year-old woman who had brief pleuritic chest pain while she was out running. I don't think it had anything to do with pulmonary embolism, but she's now fine. Someone ordered a D-dimer and it was slightly elevated. So she got a CTPA where she had tiny subsegmental PE. So she was started on warfarin. She continued running because she loved running. And then she tripped and fell while she was out running 2 weeks later and hit her head and had a subdural, which required evacuation, and then had a persistent neurologic deficit. So I think that's an example of a patient who we harmed with overtesting. She was always very unlikely to come to any harm from her original problem, and she came to harm from the treatment. So I think there's a few other questions around overtesting. Do we really need an urgent ECG on pretty much everyone? I'm constantly getting ECGs shoved under my face while I'm in the middle of working, interrupting my workflow. And I think almost all of them, apart from the chest pain, is of pretty low value. Do we need baseline anything? I don't think there's anything such thing as routine bloods. Every test should have those 4 principles applied. So most of the full blood counts we do in ED, I think, are pretty low value. The U's and E's, most of them are pretty low value. And blood cultures would be another thing. So I looked at 1 month's worth of blood cultures, and kind of somewhere just over 70% of them are inappropriate as per the Choosing Wisely guidelines. Now, the Choosing Wisely is kind of interesting. I actually think it's a phenomenon of, it's mostly ignored. And when you look everywhere, it's mostly ignored. And the question is why? Because it's a really sensible, rational approach. And I think it's a problem with the lack of stakeholder buy-in. We all feel like we're being told what to do. And doctors and nurses don't really like being told what to do. So we tend to push back and do what we think is right. But yeah, it's interesting as to why they don't. We're going to be interested to see if anyone has any other ideas as to why we don't tend to adhere to these guidelines, which are rational, which are evidence-based, which are backed by, professional societies. Yeah, Pamela.
Just have to make a plug for blood cultures. Blood cultures are really useful when the patient gets admitted.
And so that's a great example of elimination. That's because we have our frame and you have a very different frame, totally. And so it's important to hear that and talk about that. So over half those patients were sent home of the ones that had blood cultures. But yes, so if they're admitted, it may be that. Interestingly, even in the ones who are admitted, well over half of them were sent home before the blood culture results were available. So they had empiric choices made. And I guess I was going to say in a few of them, it might have made a difference, but actually of the ones who were sent home before the blood cultures were available, 0 had a change in antibiotic as a result.
But they were still negative on day 1, which is a useful piece of information.
That's right. Fair enough. Yeah. Again, Alex.
I worked in Alice Springs, and we used to have a full blood count machine that we could would spit out the blood analysis within seconds, and not having to wait 45 minutes. And I thought this was really fantastic and it's going to be great. And being a junior doctor, you cling to these numbers because it's safety in numbers, because they tell you stuff. But I found universally it was useless. It was a useless thing to do, apart from when somebody was actively bleeding, but you already knew that they were actively bleeding.
Yeah, I mean, the question is, when did the last time a full blood count really surprise you in a way that meaningfully changed your management? And I think very, very, very occasionally it does. But yeah, normally I think when you truly look, there was something else sitting there that would have been included that. Kathleen.
I just want to go back to the idea of the elderly coming in. Is there a facility that they can go to at the moment so where they shouldn't be clogging up ED? And the second thing is, is it because we're a Western culture and we have this idea that we have to live as long as we can, whereas if you're in a third world country, they just know that there's life and there's death, and they tend to accept it a bit better? What are your thoughts on that?
I think it's a good question. So the answer to the first is no, and I think there absolutely should be. I mean, ideally, I think there should be purpose-designed teams and facilities to take the care to patients where they are. So this is another provocative point which I like to make. I think you could make the argument, and I'm not arguing for it, but an argument can be made that there would be no such thing as an admission to ED from a nursing home. That there are emergencies in those people, but there should be alternative care facilities for all of them. If we frame those ED things around, what I was talking about, life and function threatening time medical interventions in patients who can benefit, you could argue that once you're in a nursing home, you fall outside that category. You absolutely need acute care, but it shouldn't be in the same place as doing the rest of the emergency medicine. Alex.
I've still got my hand up, but I absolutely agree with you. And the problem is that actually, as a society, there's two things I want to point out, that we actually don't use the word death and dying. We use the euphemisms, and we are all a bit afraid of it. And so we don't like to talk about it. So the issue of advanced care is naturally an uncomfortable one, and often one that I have to deal with in the intensive care unit, when those sorts of conversations should be happening in the first beforehand. And I think also, there's this unrealistic expectation that people have about outcomes. For example, if you talk to Alex Sarides, 75% of CPR in programs is successful, and in the UK it's slightly more pessimistic, it's 50%, whereas the reality is that it's vanishingly rare that people do well after CPR. So yeah, there's a whole lot of sort of expectation, fear, and things which sort of drives a number of these sorts of behaviours. I mean, and also I think also the ARC facilities are woefully undermanned, and they will find it difficult to manage anyone with increasing needs in the last moments of their life, and often are sent to us because of that.
So that's the problem. And then we have the resource in the wrong place, and you have a general medical wards, which should ideally be for people who needs acute general medicine, actually clogged up with all sorts of dying palliative care patients, with patients who can't really get up and have fallen over and don't have an acute medical problem, but need a strong multidisciplinary input, through to people with social issues, and then your hospital's $1,500 a day general medical beds are clogged up with those things. And so then they overflow into the surgical ward, so then you can't do your elective care, and then round and round it goes. Absolutely. And so this is again the thing about thinking from first principles. So I think we need, and we haven't had the ability as a system to go back to start from scratch and think, what would a really good system work like? Where would these different things be delivered? What are we doing? What bits of care are we doing now? Where would they best be delivered? And then let's design our system around that, rather than just piling more and more stuff in the narrow funnel that is the emergency department and then the hospital. Kathleen.
When my mother was ill last year before, she'd gone to her GP, and when he got her test results back, she was in stage 4 kidney failure. And the first thing he said to her was, "Are you ready to meet the Lord?" And then he started a conversation on what kind of treatment she wanted to make her life. Did she want comfort, or did she want... I thought it was an unusual introduction to the conversation, but it got her attention.
Yeah.
And then she could ask questions. What does that mean? What does that entail? No, I don't want this. No, yes, I want that. And eventually, fortunately, she was able to be looked after at home and got hospice involved eventually, so she wouldn't have to go to hospital. And it was, she's in the States, or was, she's passed away now, but just the whole ability of flow for that, I thought was quite well done. And in her case, I'm not saying everybody gets that, I don't know, but I thought it was well done for her and what she wanted, and was able to talk about it, and he was straight up with her.
That's fantastic. And ideally we'd be able to do that. But the problem is, even if the GP has that conversation, there's a hole we have in the resource. Palliative care is woefully underfunded. A GP actually loses money every time they go to an aged residential care facility to see a patient there. It costs them money. Most of them still do it, but increasingly they're not. And so it's really problematic. And so this last slide about the taboo topics, we've covered a lot of it already, actually, which is great. Because I think there's some excellent work being done both locally and nationally around goals of care, but there's still a long way to go. I mean, there's a less than 5% uptake of advanced care plans in over 65s in Nelson, despite kind of a bunch of pushing over the last 18 months. And every day in the ED, we're admitting multiple patients to the hospital who have no meaningful chance of benefiting from the admission. We're increasingly admitting dying patients to clear palliative pathways because of society's expectations, our lack of resource. I think there's a thing about Western cultures and the way we treat our elderly comes into things. And then does our political system preclude meaningful discussion on this? Because I think one of the things we talked about, I think most of us are on the same page with this, increasingly doctors, but they're not conversations people are having in public. And interestingly, you look at the response when Saxon wrote that article and stuff and put his head up. I avoid the stuff comment section like the plague, but I read it because I was really interested, and there was hundreds of comments, and more than half of them were really negative towards him personally. And I think we all need to be a bit braver in the way we have these discussions, because I don't think there are many doctors that wouldn't agree with a lot of what he was saying. He was talking about rationing in healthcare, and of course we have to ration healthcare, and it seems utterly obvious. It's kind of like a taboo word. I bring it up with John Bonning, and he's like, oh, we don't talk about rationing, we talk about rational healthcare. And it's like, well, no, that's just rubbish. Of course we ration. We ration any resource that's not unlimited. We can't give everything to everyone, so we have to think about the best way to use it. So there's also, I think, overlying all is this question of equity, which is a great frame to keep bringing back. The more you spend on these older groups, it's more spent on the affluent and the Pakeha. And in the context of economic growth and the potential end of economic growth, it means intergenerational inequity. This money that's being borrowed now to deliver this healthcare is paying for a level of care that it's very unlikely the next generations will receive. So if there's a few great books around this, around the kind of end of growth and thinking about how that might look, but we're basically in this economic paradigm now where we're borrowing money from the future. And when you look at those demographic graphs I talked about, the kids of today are not going to get the level of healthcare that 75-year-olds of today are getting unless something magical happens. So how do you compare a hip replacement or an angiogram in an 85-year-old to investment in social housing that may alter the life trajectory of a 5-year-old? They both come from the same pool of limited money. And so we sit in our silo thinking about our funding and how we can make our system better. But it's really interesting to zoom right out and start thinking about that real bigger picture and how we might advocate in that. So I think the concept, and a couple of people have alluded to it, that we have this dysfunctional relationship with death to be really interesting. And I think it's this emergent cultural phenomenon. So no one woke up and decided that putting a peg tube for feeding into a severely demented 86-year-old was a good idea. But that's exactly what happened to a good friend of mine's dad last year, who's good friends and anaesthetist. And somehow they ended up down this thing of putting this feeding tube into his angry, demented dad, and just caused a year and a half of suffering for his wife, the family, and the patient. So I think it's this complex interplay of public expectation, of medical perception, fear of complaint, of fractured family structures, of medical culture, and of changing technology, and it's led to this point. So do we have a responsibility for all this? How do we fit this into our busy and pressured days? And the question is, are there small things we can all do to stand up and be part of kind of changing the structure? I don't know if anyone has any thoughts about how that might look. We're kind of near the end of time, so we can.
We're actually over time, Tom.
Yeah,
and
cool. That's cool.
But it's been a highly enlightening talk, and I think the problem of our whole system siloism is a big one, and one we probably need to think about, especially as we build what we think is going to be a new hospital, and whether we need to do that. I've just been to another hospital in Australia that was replaced a little one, and they've just got the same problems they had, but it's just bigger and shinier and nicer.
mean, imagine if we looked at our problems from the ground up and thought, actually, what we've got is this burgeoning elderly population. That's going to be who are currently taking up general medical beds. If we build a new hospital like ours, and the day it's open, the general medical bed will be bed blocked. Whereas if we thought about building some big kind of, medical hotel type, lower acuity, heavily social services, allied health and healthcare assistant based facility that didn't have heavy levels of doctoring, but could take bigger volumes, that, for example, might be a far better way to look at it, just as a one tiny example of a different way of thinking. And I'm so sorry for the IT issues. That's my error in not double checking that it was Zoom based. I could have done it differently. So I'm sorry about that, everyone.
Well, that's no worries, Tom. Well, thank you very much for a highly interesting and thought-provoking talk. And I'm looking forward to you being on the Te Whatu Ora board to completely reshape healthcare in the future.
I'll do a Rob Campbell. That'd be great.
Okay, mate.
Well, ka kite.
Ka kite.